Welcome, everyone, to this November Hero webinar. I'm Karen Mosley, President and CEO at Hero, and it's my pleasure to be the host for this webinar today that is sponsored by Merative. We are really thrilled to be hosting this conversation about higher education benefits and how to manage GLP-1s. The university sector is a strong component of the Hero membership, and I know that we have many universities who are interested and curious about how other institutions are managing GLP-1s. So this will be a really informative and fascinating conversation for universities, but also for all employers in general. I would love to have conversations with any of you about membership. Universities do have access to a lower nonprofit university membership dues. And we also host every year a university summit that focuses on critical issues that are especially experienced by institutions of higher learning for their faculty and staff benefits. So I invite you to stay tuned for more information on that in 2026. If you are attending this webinar to receive continuing education credit through InCheck, please do make sure that you complete the survey as you exit the webinar. We, of course, want to hear from all of you about your thoughts on the webinar, but the survey is mandatory if you are seeking continuing education credit. At Hero, Dr. Marion Bowden, our research fellow, and I co-edit the special issue or the special section of the American Journal of Health Promotion called Knowing Well, Being Well. And earlier this year, Dr. Bowden edited an article or a whole issue actually on GLP-1s with a paper on how employers are other considerations for employers to consider as they are thinking about including GLP-1s as a benefit for their employees. That paper has been nominated as one of the best for 2025 by the American Journal of Health Promotion. So I would encourage you to take a look at that series of papers when you have a moment after the webinar. And so now it is my pleasure to introduce the moderator for today's session, Catherine Shanahan. Excuse me. Catherine is the Senior Pharmacy Analytic Advisor for Truven by Merative and is a pharmaceutical industry expert. She assists commercial and government payers, providers, and research teams in developing actionable pharmacy-related analytics, strategies, and programs. She has a background in pharmacology, toxicology, drug research and development, and began working with payers over a decade ago. She supports efforts to identify cost-saving opportunities, improve prescribing quality, reduce misuse and abuse of medications, and lower barriers to effective treatment in order to make healthcare more affordable and effective for plans and patients. Catherine, thanks so much for moderating this conversation today. I'm looking forward to it, and I'll hand it over to you.
Yeah, thanks, Karen. Hi, everyone. Welcome to our Hero session today. This is Leading Through Innovation, How Higher Education Benefits Are Managing GLP-1s. Today, I'm going to be moderating our panel, and I'll be joined here shortly by 3 Big Ten universities who will walk through how they're managing GLP-1 medications and talk about the truly innovative strategies that they're deploying within their benefits. But first, I'm going to kick us off with some high-level trends, what we're seeing across the industry, just kind of level set of what we're hearing from payers like you. We want to go to the next slide. One more. One more. Thank you. So GLP-1s have been on the market for nearly 20 years now, but it's only been in maybe the last 5 or so years that we've seen exponential growth in utilization and spend. The graph here is from Merative's MarketScan database, representing over 293 million lives for commercial health plans and employers across the U.S. And we're looking at patients per 1,000 and allowed amount PMPY spend for GLP-1 medications from 2013 to 2025. Along the x-axis at the very bottom is a timeline of FDA approvals throughout that time frame. So you can really see how each of these approvals is kind of adding into the mix of expanding utilization spend in this area. And GLP-1's been growing anywhere from 35% to over 60% each year since 2020. And we're projecting about $700 PMPY by year's end 2025. That's over 7 times the PMPY spend rate as 2020. So it really has had an exponential growth. And while we saw growth slow slightly in early 2024, by year's end, we had an increase of 32% patients per 1,000 and 62% in allowed PMPY spend. And 2025 is looking like it's going to follow a really similar trend. If we go to the next slide. So in late 2024, Merative surveyed commercial employers and health plans to understand what their plans were for the 2025 benefit year. And respondents for that made up over 4 million lives and spent $1.5 billion on GLP-1s collectively. Go to the next slide. And so the results from that survey gave us some really good insights into how commercial payers are covering and managing GLP-1 medications. At the top, we're looking at where GLP-1s are placed on prescription drug coverage tiers, and at the bottom, any utilization, management, or criteria. On the left are diabetes GLP-1 products, on the right are anti-obesity products. So most employers and health plans were covering both diabetes and anti-obesity medications on the preferred tier. However, we saw a spike in plans starting to drop coverage of obesity products, and we've heard that from around the market. We also found it really interesting how many were covering GLP-1s on their preventive tier at either like a really low or $0 out of pocket. And then in terms of criteria, most commercial payers had some sort of strategy, usually like a prior authorization, like requiring a diagnosis code or a physician attestation for both diabetes and anti-obesity products. But 23% of respondents also included participation in a lifestyle program for access to these medications. And that's something we think is really going to grow in 2026. We're hearing from many of you that implementing those types of programs is something that you're contemplating, at least as an option for patients on these medications. We go to the next slide. So, driven by the rising spend of these medications and increased scrutiny from leadership teams, finance departments, employees and members, and really the nation as a whole, data has never been more important. And so that includes profiling your GLP-1 patients, identifying barriers as like the first steps towards measuring ROI. After all, only patients who are really like committed to treatment and remain adherent are who we're seeing the best outcomes for. And so, of course, this starts with things like medical data, drug data, eligibility data. These are the cornerstones to utilization reporting, off-label evaluations, tracking demographics, things like that. But integrating other data types, it can vastly improve your strategies. Things like lab and biometric data are early indicators to successful treatment. Program data, care management data, engagement data to understand how the investments into programs can really improve the outcomes that you're seeing for these patients, for these medications. Survey and questionnaire data to understand habits and lifestyles, productivity and absence data to understand diseases beyond healthcare, how these diseases, how these medications impact a person's day-to-day life. And so all these different data types really contribute towards that innovative strategy with the aim of, again, improving access, reducing costs, and promoting the best outcomes. Yeah, so looking ahead, this topic is really, we don't see this going away anytime soon. There's estimates of upwards of 16 new GLP-1 products or GLP-1 adjacent products that are going to come to market in the next 5 years. And while some of this, increase in the number of product options will hopefully lower costs of current products in the market, some of these newer products, including some of the ones I've highlighted here, offer improved efficacy, maybe lower barriers to use, offer reduced side effects, but those kinds of improvements come at a higher cost to them. And so how you manage your medications, how you manage your formulary is really going to indicate whether or not you're going to save by utilizing maybe some of the older products where appropriate versus where it makes sense to use some of the newer products. So really how you're deploying that is going to impact your spend going forward. And so it's going to be really important for payers and vendors to consider how to manage all this kind of expanding portfolio. How can patients be matched the right product? How can we support patients in reaching their health goals? And lastly, what does ongoing care look like once health goals are met? So once, let's say, they've reduced their diabetes risk, maybe once they have reduced their weight, what does maybe an off-ramp or a migration into maintenance care look like? And I know some of the panelists today will talk a bit about that, what they're exploring, but these are areas that I know are kind of the question mark for a lot of payers across the industry. If we go to the next slide. So with that, I'd like to move into our panel portion. I'm joined by three really fantastic universities who are going to share a bit about how they're navigating GLP-1 trends and the strategies they're deploying. I do want to start, before you guys introduce yourselves, I want to start by thanking you all for agreeing to speak on our panel today. We're really thrilled about some of these solutions that you guys are going to talk about. I know this is, a really big topic in each of your organizations. And so really appreciate you guys sharing. So to kick us off, can I have each of you kind of go around and introduce yourself, your organization? Do we want to start with Stephen and then go Rita and then Katie?
Sure. Hi, everyone. I'm Stephen Lott. I manage the prescription drug benefits for the University of Michigan.
I'm Rita Bartolacci. I'm the benefits strategist for Penn State University.
And I'm Katie Collegiate. I'm the Director of Benefits and Time Away at the University of Minnesota.
Awesome. Thank you. Thank you all. Do you want to go around and maybe talk a bit about your universities, talk a bit about kind of your benefits, and then maybe an interesting fact about each of your universities, kind of give us kind of an intro of your coverage, your benefits, your coverage population, things like that.
Sure, I'll start again. So at the University of Michigan, we have a carved out pharmacy program, which means that we have health plans that we offer our members, but they all have the same prescription drug benefit that we manage in-house, which does make the University of Michigan a bit unique in that way. Not many other employers or universities do manage their prescription drug benefits completely in-house. We do have a PBM that we use, but the formulary that we have is completely custom. It's managed by a team of people within the benefits office at the University of Michigan and Michigan Medicine, our hospital or health system rather. So we have 125,000 lives. It's spread over 3 campuses: Ann Arbor, Dearborn, and Flint. And then we also have the health system. So kind of four buckets, which comprise our population. Interesting fact about the University of Michigan: we were the first university to own and operate our own hospital.
That's really interesting. And I know we're going to touch more on some of the topics of how that's integrated and how that's working for you. Rita, do you want to go next?
Sure. So I am the benefits strategist at Penn State University. Our main campus is located in State College, Pennsylvania, or University Park, which if you put a dot in the center of Pennsylvania, that is where we are located, at least our main campuses. We do have 21 other campuses. Our smallest 7 are actually slated for closing after the 26-27 academic year. Those campuses all have less than 300 students in attending those campuses, and most of them only offer associate degrees. But we do have a campus within most areas of Pennsylvania, so most students are only within 45 minutes of a campus to be able to receive on-site instruction. We also have World Campus available. We have about 19,000 employees that are members of our health insurance plans, and that covers approximately 45,000 covered lives. One thing we're famous for, well, our football stadium, second only to Stevens football stadium. We have about 1,000 less seats in it. I had to look that up, Stephen. But something we're famous for is our "We Are Penn State" slogan. And in the 1948 Cotton Bowl, Penn State was invited, but asked to leave its 2 Black players, Wally Triplett and Denny Hoggard, at home due to Jim Crow laws in Dallas, Texas. And the team captains team captain Steve Suey reportedly stated, "We are Penn State. We all go or no one goes." And they actually were able to play the full uniform team, marking the first non-segregated African American athletes were able to participate in that Cotton Bowl. And it was the first time that there was a non-segregated game in collegiate athletics. Our football player cheerleaders, however, brought that chant back in the 1970s to generate more fan enthusiasm in our stadium. If you've ever been to a football stadium, Penn State's rocks, and literally, and that chant of "We are Penn State" echoes throughout the stadium many times, so it was obviously successful. Our health plan, we do currently cover GLP-1s, and I'll get into that a little bit later, I think, as we talk about some of the challenges and in our coverage.
That's amazing. What an amazing look, chant, and to kind of carry that on. That's really fantastic.
Right.
Katie, do you want to go next?
Absolutely. So representing the University of Minnesota, a little bit about the university. So our main campus is located in the Twin Cities in Minnesota, separated by the Mississippi River. We also have 4 other campuses in Crookston, Duluth, Morris, and Rochester. We have about 20,000 employees that are on our medical plan and about 42,000 total covered members. Similar to Michigan, we also have a carved out pharmacy benefit and play an active role in the clinical management of the formulary and pharmacy plan management. A couple things we're famous for in Minnesota is we really have I would say, a demonstrated history of healthcare innovation. A few examples of that. In the 1960s, the world's first successful kidney, pancreas transplant, and successful bone marrow transplant were performed at the University of Minnesota. And a big outcome of the 1990s, also originated from the University of Minnesota, was the creation of the Honeycrisp apple. So very proud of all of our contributions, including those 3.
Awesome. That's really great, Katie. Thank you. So yeah, I thought we could jump into some discussion on GLP-1s. Like, I know that there's a lot of differing coverage of these medications. I know a lot of payers are kind of working through how they want to cover them, if they're going to cover all types of products, if there's certain conditions they want to cover them for. And then obviously within each of those decisions, there's a number of challenges. You know, you're kind of between leadership teams and finance departments and your members. Do you want to talk a bit about, for each of yours, how you're covering GLP-1 medications and the types of challenges that you're facing in these spaces?
Sure. I'll kick off. So we do cover GLP-1s for weight loss. We've actually always covered weight loss drugs, at least as long as they've been on the market. Starting with Saxenda. I know Catherine, you had the slide with the timeline. It's been out for a very long time. We hit the market in 2021, I believe, around there. And that's where we really saw the demand take off, and we had to really figure out what we're doing with our strategy. We had a fairly strict prior authorization requirement for those earlier weight loss drugs, and initially we just carried on that same weight loss PA requirement. But through 2021 and 2022, when we saw the demand really take off, we had to really assess our requirements and what we needed to see to continue allowing coverage, because we saw this huge demand and these costs that were really building up. So we have a fairly strict prior authorization requirement for GLP-1s. We chose not to receive the rebates for these products because the demand kind of outweighed the rebate benefit. And if we just opened up coverage to everyone who was seeking them at the time, the models that we built in-house just were kind of crazy. So we have a type PA, and that includes a BMI threshold that's actually higher than the label. For coverage, you have to have a BMI of 30 or more, plus a risk factor like a comorbidity, or a BMI of 35 and up. We also require trials of the oral medications that are on the market. There's 2 specific ones, Qsymia, which is now a generic, and Contrave. And we also require a 6-month lifestyle program attempt before coverage of the GLP-1. What's a bit unique too about our coverage for GLP-1s, which we'll probably talk a lot more about in the next couple minutes, as we only covered 2 years of coverage for GLP-1 for weight loss. So it's 24 fills, 1 month fills, which I haven't seen too many other employers do that strategy. I know a few of them, a few employers at the time did something similar, and at the time too, the UK also limited coverage to 24 months. But that went into effect in 2024. So in 2026, we'll start to see some of those first kind of people that have exhausted their benefits hit the not hit the market, but we'll start to see some of our members exhaust their benefits in 2026 due to our 24 fill policy.
Yeah, and I definitely want to talk about that later because I know that that's a topic that I'm hearing coming up more is kind of this off ramp and what do we do, or the maintenance phase, and how do we manage that? So definitely we're going to touch on that later. Rita, do you want to talk a bit about how you're covering GLP-1s and some of the challenges you're facing?
Sure. So for GLP-1s, our pharmacy benefit, by the way, is carved out just as it is with for the University of Minnesota and the University of Michigan. We do have prior authorization for GLP-1 medications. And I'm trying to, hang on a second, I just lost my notes. Okay, there we go. So we do have prior authorization required for our GLP-1s, BMI of 27 for diabetics, and that also requires a proof of a diabetic diagnosis other than just a metformin prescription. So proof of an HbA1c, fasting plasma glucose, or hyperglycemia documentation, and failure to control with other medications such as metformin. For weight loss only, the BMI requirement is at 30 right now. We also have approvals for Zepbound for sleep apnea and cardiac issues as well. And something that, I think is going to increase, and I'm sure we'll talk more about too, is the increasing number of conditions for which some of these GLP-1s are being approved now, and whether or not we're going to be covering those in the future. We actually are switching our pharmacy benefit manager for 2026 from Highmark Blue Shield, which is our current TPA, to we're carving it out and going with CVS Caremark for 2026. But we are going to continue to cover GLP-1s for 2026. So we have done a custom formulary to be able to include Zepbound and other GLP-1s.
Yeah, that's interesting, especially your comment about the diagnosis code. I know that that's something that we're seeing with a lot of payers is kind of the creep in of if attestations or allowances for history of drug, metformin, for example, and so being able to verify diagnosis is
because unfortunately, we did find that there were some individuals who were being prescribed metformin for a few months and then switched to a GLP-1 with no other documentation of a history of diabetes because they wanted a higher level of coverage.
Yep.
And they wanted to guarantee that if we did carve out at some point and did not cover GLP-1s for weight loss, that it would be covered for them.
That's interesting. Yeah, is that continuation of care and making sure that they have it, then let's make sure it's documented.
We also had to switch a lot of individuals. We did find that we had, as far back as like 2021, 2022, we had a lot of individuals who were on Ozempic instead of Wegovy, who did not have a diagnosis of diabetes. And we found that we had individuals who were on tirzepatide and the formulation for diabetics as opposed to being on Zepbound for weight loss. So we ended up switching those because there is a cost savings associated with having individuals on the correct medication, for the correct use.
Exactly. Interesting. That's really interesting. That you went through. Katie, do
Yeah,
you want
that
to-
was using the Merative database. We were able to use our health insights and utilize that in order to be able to, determine that we had those individuals that were on the wrong medication, essentially.
That's right. And that's exactly where data can really kind of help you with those kinds of decisions and looking at where there's gaps or where, you might have, within your benefit, how people are using the medications. And to your point, you just want to make sure that they're using the right medication, that they're getting the right care, and that they're aligned correctly with what their diagnosis is.
Exactly. Yeah. So, our consultant with Merative was instrumental in helping me design, reports to be able to prove that out and determine, that we had several hundred on each that were on, each of the different medications, the tirzepatide versus the Ozempic. And so we were able to then reach out to Highmark and have them reach out to the individual patients since our claims data is de-identified.
Yeah. Yep. Exactly. That's super interesting. Yeah. Katie, do you want to talk a bit about, how you're covering and some of the challenges you're facing?
Absolutely. So at the University of Minnesota, we cover GLP-1s for both weight loss and diabetes. We do have prior authorization criteria in place, and it takes into account things just as kind of Rita outlined too, things like BMI and comorbidities in certain circumstances. Looking at our structure and how these benefits are covered under our prescription plan, we have a 3-tier prescription drug benefit. And it's copays for our we have an HSA plan as well, but coming to our copay plans, it's a 3-tier structure. All of the copays are pretty reasonable in terms of benefit design. The highest one is $75. So these prescriptions fall in are either tier 2 or tier 3. But it's worth noting that with manufacturer coupons, we can generally see these actually come through for what the employee is paying as either 25 or sometimes no expense to them. So that's kind of what we're seeing in terms of our coverage and how it's covered under our plan. In terms of challenges, there's a few things that really jump out when we look at our data warehouse and how we're kind of tracking GLP-1s. The first is spend, as I'm sure many of us on this webinar are tracking. We can see in our reporting that we've done so far through September that in 2025, we are on pace to be significantly higher than 2024 when it comes to GLP-1s. And as I mentioned, sure, I'm not alone in that. So I think that that's a huge challenge that we're seeing, and then also adherence rates. So we just continue to monitor adherence rates. It's not where we want it to be, and at the same time that adherence rates isn't where we want it to be, our utilization keeps rising. So we really have a challenge there when it comes to GLP-1s. And I would just say broadly, when I think of the challenges that we're facing, it's really how high these prices are for GLP-1s, how many people qualify to use it, and then how long they're staying on it. So we just really feel like it's a challenge that's kind of keeping us up at night in terms of how to make a strategy decision around this. And I guess we'll talk in a little bit about some actions we have started to take.
Katie, I have a quick question for you, like related to that. I was wondering, like, if you think that it's because maybe employees don't have enough skin in the game, so to speak, in terms of copays, because we have super high adherence, and but our employees are paying anywhere up to $500 per month for GLP-1 medications, depending upon where they're at with their deductible, whether they're on a high deductible health plan or a traditional PPO, et cetera.
I think you bring up a good point, Rita. Because of our copay design, we could see some adherence issues related to that. I think, like many of us on the call, we're challenged in kind of making changes to our plan design. But I think that with just in terms of like sometimes things that are in labor agreements, for example, but I think that issues like GLP-1s really bring that to the surface, and kind of using the data really helps us get a clearer picture of kind of what's going on, and making the case for a long-term strategy around plan design, perhaps. So it's a good point.
I think it helps for us to be able to network together too, and, you know, talk about our individual challenges, because when we look at them together, we might see some insights from each other's plans.
Absolutely. Yeah.
Stephen has a really interesting plan design with his 24 months of coverage.
Yeah, and I was just going to add on to the talk about adherence. We see very high adherence in our plan as well, very high adherence and also persistency, which means once they start taking the GLP-1s for weight loss, they tend to stay on the GLP-1s for weight loss. We don't see a large drop off in our membership. And there's probably a couple reasons for that. One, because our prioritization criteria is fairly challenging to meet. You have to do a lot to meet it. You have to try the orals, you have to do the 6-month lifestyle program. By the time they actually get access to the GLP-1s, they are pretty committed and they want to stay on that GLP-1, just because of the amount of kind of effort it does take to qualify. And also the 24 fill cap, I think motivates others too to, or at least encourages people to stay on it, because they know that they have this benefit that a lot of our peer institutions, a lot of universities don't offer GLP-1s for weight loss. A lot of employers in the private sector don't offer GLP-1s. So they know that it's a benefit that not everyone has. And it is kind of a nice thing to be able to offer to our employees. So we see a very high adherence, very high persistence. And I think a lot of it has to do with the prioritization criteria and what the patient or the members have gone through up until the time they start the GLP-1.
That's an interesting point. That is a really big difference that we're seeing in real world data versus what we saw in like clinical studies, is that difference in adherence and persistence that in a lot of the clinical trials that showed all this great efficacy, how well these drugs worked for patients. It was that they were adherent to them for quite a long time, usually at like a minimum, I think it was like 10 months. I think mostly it's 12 months plus, you know, and so yeah, you're going to see really fantastic outcomes, but real world, we're seeing a lot of side effects. We're seeing a lot of patients kind of struggling with the lifestyle changes, struggling with support through that. And it's leading to, you know, a lot of drop off, I think, in the first few months, especially, or at least, you know, when they're changing doses and things like that, you know, so a lot of that I know is a challenge. And so how do you work through those pieces, to your guys' point? So I think on that, you know, what are some successes then that you've found in managing these medications? What has been working? I know, Stephen, you're just talking about that, having that kind of lead up is leading to better persistence. Is there other things too that you're finding, you know, is really successful with your management strategies?
I think that's really the key, is just the utilization criteria, and finding those patients who are motivated enough to want to stay on the medication once they have access to it. Our populations are probably very different from other populations, and if there's no barrier to receive a GLP-1, Rita mentioned earlier the skin in the game. You might see a lot of oh yeah, it's whatever, my insurance covered it, I'm gonna try it. If it doesn't work, oh well. I think finding those people who are really motivated and dedicated to lose weight is one of the hardest things to do. But once you find the patient that's motivated and willing to stay on the therapy long term, that's a good way to find success with these products.
That's a great point.
And I think, you know, because of the high cost that employees have in some cases at Penn State, you know, once they're no longer able to get the cards for, you know, the savings direct from the manufacturer or copay cards, and then, you know, they're going to have a really high cost to stay on that medication, unfortunately. And so I think it, you know, if I'm paying $500 a month for it, I'm going to take that medication and, you know, work through those side effects and, you know, potentially make my doctor aware and try to work with my physician to mitigate those. Being a nurse, I kind of always think of it from a clinical aspect as well.
Yeah, that's a great point. Yeah, Katie, is there something that you're finding successful?
Yeah, I'll add that we've really invested in our strategy around our pharmacy benefits just as a whole. So we added someone to our team, Summer Tran, who couldn't be here today. But she joined our team in 2024 and is a pharmacist with expertise in pharmaceutical economics and policy. So she has a PharmD and a PhD and works really closely with our College of Pharmacy at the University of Minnesota. So kind of with her joining our team, we've been able to really elevate our data analysis strategy and kind of work with her health plan expertise and look at things like GLP-1s. So just some examples, she is working closely on tracking the adherence, kind of potential strategy adjustments, but really, and I think this is, so important and something I'm sure we're all centering is just really making sure that we're, keeping in mind those health outcomes, because the last thing we want to do is add a barrier that then we're not seeing one of the folks on our plan like supported when we want them to be able to achieve the health outcomes to support their health and the health of the plan as well. So Summer's been really instrumental in getting that strategy off the ground and starting the data analysis and kind of mapping that strategy for that. In terms of
the concern we have too, is that because of that high cost that individuals might not have the, those gains in terms of losing the weight and the better health outcomes from that.
It's a challenge, and I think something we're all watching closely as more studies come out and we're seeing more data come out. Like we're looking to track, like, are we seeing improvements in comorbidities? Are we seeing less ER visits in this population? Like those types of things. Again, a little early for us to know on all of that, but important that we are tracking it and kind of mapping a strategy around that as well. One thing we have done is implement a 30-day supply. So we actually just did that earlier this month. And, we know from the work that Summer does on the plan and just data around this that, I think it's perhaps working a little bit better with Michigan and Penn State when it comes to adherence, but we know our members in Minnesota aren't alone when we're kind of having challenges when it comes to adherence with these medications. So we will be tracking kind of adherence along with kind of continuing to monitor that along with this 30-day supply to see the impact of that on the plan.
I'll be interested to hear how that works out as well. Because right now we do have availability of a 3-month supply. And, we're wondering how much waste there is when someone's potentially changing dosages, and not wanting to, whether or not they're using up that stock that they have of the prior dose.
Yeah, that's exactly it, Rita. Yeah.
We've done a lot of custom coding with our PBM as well. I'm not sure how detailed I should be here, but for all GLP-1s, because we saw a good bit of waste of people getting 3-month supplies of a low dose by accident, or maybe the doctor wrote the script incorrectly or the pharmacy had an error. Every time a patient or a member jumps up one strength for the diabetes, GLP-1s are limited to 1 month at a time. They can get 3 months at a time, but they have to try that 1 month of the new dose first before they can get the 3-month supply. Because of the tolerability issues with these products, people go up a dose, they can't tolerate it, they go back down a dose. And so we limit the dose increases to 1 month for the initial fill, and then they can fill 3 months if they can prove that they can tolerate that dose. For the GLP-1s for weight loss, though, those are not, we don't allow 3 months supplies for those. Those are 1 month at a time only.
Okay.
Yeah, it's interesting. The same type of setup with the same type of strategies and kind of deployed a little bit, but like it very much those types of strategies reduce waste, make sure that patients are getting access to the medications, but yeah, that we don't have this residual medications in it, because they change doses and now they're having to throw that away. And, those are great strategies kind of deploy and kind of evolve.
I think we're going to also be looking then at our Health Insights database to be able to look at how many days scripts are being filled for and comparing that, for these medications so that we can really take a look at how often this is happening and how much waste potentially, as well as how many doses on hand an individual is pre-filling.
Exactly. Yeah, exactly. It's yeah, how many duplicative scripts, but yeah, exactly. Are we seeing day supply go beyond the time frame? Are we seeing, multiple doses for a patient in the same month, things like that?
Yeah, so I think, having that data available to us is going to be important for all of us as we move forward and try and monitor that.
How about challenges? I mean, are there things that you want to warn others about, something that didn't work, some like a lesson learned that you've kind of faced? And I know we've kind of talked about it, maybe touched on a couple of those, but are there things that you've kind of, as you've worked through your strategies, things that you found that you're like, this didn't work, or this, I needed to fix this, or I need to change this?
I can start with this one. Oh, yeah. Something that I think has been, I don't know, a challenge or something that we've been keeping an eye on is the prescriber of the GLP-1s. I don't know if anyone else has encountered this as well, but when we have done a deeper look into the data, we've started to see prescriptions from GLP-1s come from providers who really, might not be qualified to prescribe these medications for what the, the indication. So, for example, we've seen GLP-1s prescribed from anesthesiology, dentistry, emergency medicine, so things that don't make sense. So, and we, are concerned because I feel like that could lead to safety concerns, inappropriate use, and again, just continued higher costs to the plan. So I think it's important for employers to kind of partner with their PBMs in this area and making sure that PBMs are prescribed by like appropriately qualified providers. That's one thing that we've seen come up recently. And then another thing, and I would just say a challenge, I don't know if that's the right word to describe it, but something that we're really facing when we're looking at GLP-1s, warning might be a little strong for this, but I would say that like with the continued indications, so as the FDA continues to approve GLP-1s for more conditions, like I know recently it was the MASH, the liver disease as well, we're just going to see more folks qualify and continue to see the costs rising and kind of stress on the strategies that employers have in place to continue to provide these benefits in a productive way for their employees. So those are a couple of the things that we're keeping an eye on at the University of Minnesota.
Yeah, that's great.
So
How well do you think that follow-up is going to be with that anesthesiologist? Are they meeting with them every month to verify that the side effects are going well? Probably not. And so, yeah, to your point, how well is that how well is that patient being managed?
Exactly. Yep.
We have some challenges too. We actually had WTW, our consultants, run scenarios with regard to cost share, and any attempt in capping the dollar amount that individuals or the university spends resulted in such a loss of rebates. It was more than we would gain in the savings, no matter how we structured this. Covering it for 30 days only, covering only up to $4,000. Everything just had such an impact on rebates, which are getting a lot of press right now from is it PRHMA? About there are a lot of ads out there about 50% of the cost, being impacted by rebates that, well, it's affecting us. If we would try to cap the dollar amount that individuals or the university paid, so much so that it's not cost effective for us to do so. And it affects all of our rebates, believe it or not just the rebates on the GLP-1 medications. So that has been a really big challenge for us, and something that, before another university or another organization would make an attempt to cap dollar amounts of coverage, is take a look at the effect it may have on your rebates.
That's a great point. Especially transparency into rebates is obviously very, very great. No, I'm kidding. But
yeah, and I mean, we have 100% pass through, but
yeah.
Still, it's a huge impact.
Yeah.
Yeah, you could talk rebate strategy all day on another call, but lucky for us, we never got rebates for weight loss drugs to start, so we didn't have any rebates to lose. But yeah, to qualify for the rebates, we would have to basically cover to label, no restrictions at all, and we did the math and figured out even with it was around 50% off. We were saying like basically dropped them down to like 500, kind of similar to the cash price programs that are out there now for direct to consumer pricing before they drop next year. Even with the rebates, it just the increase that we would have seen with coverage was just too much for us to afford as a university. So that's why we went down the path we did with the PAs to manage utilization versus trying to maximize the rebates.
Interesting. So what about going forward? What about 2026? What are you all working into your strategies? What are you looking at? I guess I could say 2026 and beyond. What are you looking at going forward? What are changes or things that you're, at least either tracking, monitoring, or changing about your benefits?
Yeah, so we don't have any major changes occurring for 26. However, as I mentioned earlier, that's when the first wave of people who have exhausted their 24 fill limit will start appearing. Yeah, we've already handled a couple questions, some concern from our members. There are some strategies that we're working with our providers internally at Michigan Medicine and University of Michigan Health. The oral medications are still out there for patients. Those could be effective as maintenance doses for many people who have lost the weight just to maintain their current weight. Generic liraglutide we've had our eyes on for a while. Unfortunately, the price hasn't dropped yet, but we expect a few more manufacturers next year. So it is a daily shot, but it's a GLP-1 that's generic. And if the price is right, it could be an option for patients to continue on beyond the current 24 fills that applies to the once weekly doses right now. The direct-to-consumer pricing, that's something we have our eyes on, and it's something we're following pretty closely. It's $350 starting. Well, I think it's Novo Nordisk, I think, launched their pricing already. But the availability of these to be purchased just with cash at a somewhat lower price should take some of the demand off from the plans. We've already seen a pretty significant drop in demand over the last year, I think mostly due to the direct-to-consumer availability in the compounding pharmacies. So that's something we're going to keep our eyes on. Most employers won't be eligible for those prices at $350. It's just a cash price program at the moment in Medicare and Medicaid price, but that's something we'll be monitoring over the next couple of months.
Yeah, how to take advantage of those direct-to-consumer prices. How can you better, make sure that either benefits are set up to steer people to those, to be able to take advantage of those discounts, how to, best set up. And I know I do want to make sure to ask about the max of 24 months. I know that we had talked about this before, but could you talk a bit about how you communicated that to members? Because I know that that's always a concern is, being surprised. And I know that that's not the case. So I wanted to kind of give you a chance to kind of talk about like how you did that communication, because I thought that was really fantastic.
Yeah, so we did update our website, our internal or external public-facing websites, but we have a program set up with our PBM. So when a patient first gets their first fill of a GLP-1 for weight loss, they do get a letter from a PBM just reminding them of the 24 fill limit. We do cover a couple kind of companion services like Amada. We have some internal programs too at Michigan Medicine, like the low carb journey that we promote via the letter. And that just gives the members some more resources and more areas to explore in terms of their weight loss journey. And then at their 16th fill, we do the same letter, just slightly modified. Just to remind them that, hey, you have 6 more fills on your 24 fill lifetime limit, just in case they never got the first or they forgot, just as a reminder. So they do get notified at least twice along the fill path.
Yeah, that's fantastic. And that I think that communication helps with your benefit strategy. And so that's something I really just want to kind of make sure to call out is those kinds of like continued communications about benefit changes. And even if it isn't, exactly the 24 fills, if you're even just changing how you're covering, if you're raising BMI, if you're being able to make sure that you're communicating, that there's constant communication and finding ways to kind of deploy those like throughout fills, throughout their providers, however that is. I think that's really great. Rita, how about you? What's on the docket for 2026 or going forward?
Well, I can tell you that after today's conversation, we're going to be looking at potentially only allowing appropriate prescribers to be able to prescribe these. I'm going to take a look at our database and see who's actually doing the prescribing. So thank you, Katie, for that insight. You know, we are right now evaluating whether or not we will be covering or continuing to cover GLP-1 medications. As I mentioned, we are moving to CVS Caremark as our PBM for 2026. So we will cover the GLP-1s in all categories using a custom formulary throughout at least the first part of 2026, probably the first 6 months at least. And then we're going to be taking a look at whether or not we're going to continue to cover, because honestly, if we don't cover them, not only could there be potential health outcome impacts on our population, but there also could be, again, a large impact on overall rebates. And, you know, if it's not going to benefit the plan and the when it comes to the bottom line, why would we discontinue providing a benefit that has proven pretty much to be such a big effect on health outcomes overall for the general population?
Great point.
So we're in a look-see mode.
Yeah. Yep. No, that makes sense. And especially I think with the PBM change, that can be a lot of change into itself. And so yeah, seeing how that goes in this next year, I'm excited to see.
Mm-hmm.
Katie, how about you? Yeah.
At the University of Minnesota, so I think we're going to build on one of my earlier points about our data warehouse and analysis and really looking at outcomes data in our population as more time has gone by. Seeing again, are we seeing reductions in things like ER visits, comorbidities? Are we seeing a reduction in cost in other areas? So a big part of our strategy will really be understanding both our data and then also kind of what we're seeing externally as well. And then, you know, aside from the 30-day supply limit I mentioned previously, we are also in the process of issuing an RFP for a pharmacy benefit manager for 2027. And GLP-1s and GLP-1 strategy will certainly be really something we're paying close attention to as we look at the RFP responses. We're going to be looking for things like level of transparency that we can get from the PBMs, spend monitoring, appropriate use, just for some examples. So I think that we could see some more changes coming ahead as we do this RFP process and learn more through that.
Yeah, those are great. And it's leaning on your vendors to be that kind of vendor partner and to help you with this challenge of, you know, you want to provide this care for patients, but it's obviously coming at like a huge cost. So that's really fantastic is to work through that. So before I open up to Q&A, was there anything else that you all wanted to share? Do we want to go through past some of the questions in the last few minutes of our session today?
I think we can go through the questions maybe. Did we have some that were pre-submitted?
There are lots of questions and not likely that we would have enough time to get through all of them. So I am understanding from our sponsor that we will commit to following up after the webinar with responses to the questions we don't get to. So we'll just right off the bat, we'll start. Katie, there was a clarifying question. Sorry, not Katie, Catherine, I apologize. Catherine, there was a clarifying question in your opening slides where you talked about $1.5 billion spend this year. And so there was just a question from Eric. Did spend mean the plan paid amount?
It includes both plan paid and member paid. So it is total allowed amount through the plan.
Terrific. And then for all of the panelists or anyone who wants to answer this next question, I'm curious how members who don't qualify for any of the obesity drugs, however, are overweight or continually work to maintain their weight by how they move, eat, manage their stress, and sleep, how are they provided an equitable benefit?
I'm happy to comment on that. You know, we feel that the qualification for weight loss, that the BMI requirements really are what determines if someone is overweight or not. And, you know, individual perception of being overweight may not always match what a clinical diagnosis of overweight is. So we only want to cover these medications for individuals who are clinically overweight and who meet the requirements that are specified, you know, for the medications, and, you know, the recommendations that the manufacturers put forth in terms of BMI and, you know, being a measure. Although I think we probably can all agree that BMI is not the only measure of overweightness. And, you know, whereas some comorbidities may also help to determine that.
Yeah, I can just add on to Rita's points there. We spend a lot of time working with our physicians on our policy. And every year when the policy gets tweaked or revised, we have a lot of initial discussions with our weight loss providers and our physicians and our P&T. BMI is a flawed metric, but it's one of the only metrics that we can really use for this drug class, unfortunately. But the comorbidities is probably BMI plus comorbidities is probably the more important kind of population level policy combination that we can use to really make sure that the medications are going to the people that are most at risk, and so the dollars get most appropriately allocated. So our coverage is BMI of 30 or up with a comorbidity, and those are the patients that are more at risk than, say, BMI of 32, but with no comorbidities. There is the equity concern, but that's always going to be a concern when the medications cost so much and there's only infinite resources. So we just have the responsibility to make sure the resources are used most appropriately, the limited ones we have, to make sure that those at most risk are treated. And then as drug prices fall, we can treat more and more patients, but it's just unfortunately the reality of our healthcare system.
I think it's also a call to, I can't tell you how many payers I've worked with that have maybe are covering the obesity GLP-1s, but aren't covering some of the non-obesity, non-GLP-1 obesity medications. They're not covering, like Stephen was mentioning before, Kisemia or Contrave. And I'll even, those are more like long-term. There's Ali, there's a couple of these kind of long-term obesity medications that are significantly less expensive, but it's make sure you check your formularies that these are covered if you're also covering obesity GLP-1s, because they do offer also an option for patients outside of kind of these higher costing medications.
Catherine, I just want to add, you know, it's so nice to have you as a resource for all of us too, you know, to be on that Merative team, because, you know, your insight as, you know, as a PharmD helps us, and with all your expertise, you know, especially in this particular category, you know, I think is invaluable to all of us to be able to help us, you know, make these determinations and, you know, look at where we can best spend our resources.
Thank you. I appreciate that.
So we'll try to get one more question in before we have to end. What methods do you use to track or monitor adherence rates? Measurement is critical. What do you do?
You know, our expert who works more closely with the data could answer that in a more complete way than I can. So I could provide more information to Catherine on that, but I know it's something she tracks closely.
Thanks, Kate.
We use
Yeah.
portions of days covered, PDC, which is a metric. There's equations out there. Yeah, we just have, that's how we track adherence.
Yeah.
Yeah,
and
we
you'll
utilize our the data warehouse and in order to track adherence and, you know, number of days prescribed, number, you know, we look at the reorders and all of the metrics that are available on the new dashboard.
Yep. And it is honestly, it's something also where you want to make sure that you are removing patients that maybe have stopped the medication, but for valid use. So we like to remove things like patients who have a pregnancy in the current year. Oh, that's a great example. If they're taking GLP-1, they're going to stop taking the GLP-1 once they find out they are pregnant. And so you don't want to really include them in your adherence, measurement. You just want to kind of take them out because they're stopping for a valid reason. So those types of validations and verifications when you're modeling that.
Terrific. Well, we do have many more questions we didn't get to, but we will aim to get those responses when we post the recording, maybe to the webinar, to the Hero website. Please join me in thanking Catherine and Stephen and Rita and Katie for joining us for this discussion. So very informative, so very well aligned with the paper that I mentioned earlier by Dr. Bowden and the strategies that employers are using to manage this cost and need for so many of our employees. I'm going to end with a shout out to Rebecca Kelly, who, because it ties into our next Hero webinar, Rebecca says studies are showing that an initial 3-month period of intensive lifestyle management prior to starting GLP-1 or other anti-obesity medications meaningfully improves outcomes. This on-ramp has been associated with greater adherence and compliance, more sustained weight loss, higher engagement, better self-efficacy. And so we will be hosting a webinar on lifestyle as medicine, presenting results from our grant-funded work by Ardmore Institute of Health with case studies from Metro Nashville Public Schools and 3M on December 2nd. I dropped the link to register. I hope to see everyone back again. But until then, I hope you have a happy Thanksgiving. Thanks all.
Thanks, everyone.
Thank you. Bye.